Good afternoon, everyone. On the behalf of Unit 1 of Ophthalmology from Dr. Rajendra Prasad Center for Ophthalmic Sciences, which is a center of excellence as far as ophthalmology is concerned, we are presenting a very interesting case. Very rare case, but very interesting case. The most important thing to emphasize here is that this case was detected asymptomatic. This is to make aware that you have to get your eye examination, and that is very important. Like in this case, she never got examined and she spontaneously, incidentally detected some retinal lesion, which was too late, and we have operated. Second thing is, whenever there is a ocular disease, you must see the systemic association and find out whether there is a systemic association or not. Second objective of presenting this case is, well, there are various systemic diseases in which eye is involved. And to highlight you, one of the common diseases is diabetes. And in diabetes, you will be surprised to know we are getting patients from various parts, even including doctors, when they present with diabetic retinopathy, PDR, vitreous hemorrhage. They know they are diabetic, but they don't get their eye examined. Second is glaucoma. There are so many patients who have glaucoma due to various reasons, and if they detect it earlier, the blindness can be prevented. So that is to make highlight. You should have your fundus examination, particularly the optic disc. You should have an image to see. And here I would like to emphasize that all faculty members about the age of 45-50 should get their eye examination, particularly appellation tonometry and disc examination. Second thing, second thing is age-related macular disease. So these are the two things, macula and disc. That should be seen. Now I invite to present an interesting case Dr. Suresh Nayak, who is our senior resident in Retina Unit. She will be presenting the case. Thank you.
Thank you so much, sir. Good afternoon, everyone. So coming directly to the history of the patient. So the patient is a 26-year-old female resident of Gorakhpur with the chief complaint of irritation in the left eye and headache for the last 1 year. So she presented with it, to us in March 2020. She first went to a local practitioner who gave her a topical medication, and similar episode happened 3 days later. So while rubbing her right eye during this, she noticed a diminution of vision in the left eye. So she presented to RP Center in April 2020. There was no history of trauma, no history of any other systemic illness, no history of any previous surgery or family history. Coming out of general physical examination, she was conscious, well-oriented to time, place, and person, moderately built. Her vitals were normal, and she was afebrile. The systemic examination was done. CVS, respiratory, and CNS examination were normal, and abdomen was palpated. No organomegaly was present. Coming on to ocular examination. First, the right eye vision was 6/6, but the left eye was 3/60, finger counting at 3 meters, not improving on pinhole or on refraction. The extraocular movements and the adnexa and the lids were normal. The anterior segment, which includes the conjunctiva, cornea, and anterior chamber, were normal. No evidence of uveitis was found in either of the eye. The intraocular pressure was normal in both the eyes. The fundus in the right eye was grossly normal with a good vertical oval disc with well-distinct margins. A cupping of 0.2:1. The neuroretinal rim was healthy. The arteries to vein ratio was 2:3. The foveal reflex was sharp. Whereas in the left eye, as you can see, the superior, inferior, and the nasal margins were discrete. But the temporal margin has a cavitatory lesion. As you can see here, there's a cavitatory lesion in the temporal part of the disc with submacular fluid present. You can see this is the border of the submacular fluid. So we went ahead with an OCT, that is the optical coherence tomography. This is the normal retina, and this is the retina that has been raised due to a neurosensory detachment. So this is a submacular fluid. And as you can trace back to the optic disc, you can see there's a pit-like structure going into the optic disc. So usually this is a clear-cut case of optic disc pit. Now we have some differentials of acquired optic disc that can be seen in glaucoma and myopia patients. So we went ahead with a visual field which is normal in the right eye, Left eye visual field was not possible because the vision in the left eye was poor, and the GVF cannot be done at a vision of 3/60, which the patient had. The refraction, the patient was not a high myopic, she was mildly myopic. Systemic investigation, only few blood investigation was done so that we could clearly go ahead with the surgery. Now the diagnosis was a clear-cut case of left eye optic disc pit with maculopathy with no systemic anomaly, and right eye was within normal limits. Now we went, because the patient presented to us with a vision of 3/60, so we went ahead with a left eye pars plana vitrectomy with internal limiting membrane peeling and gas injection. Now this is the intraoperative video. So as we can see, this first a core vitrectomy was done. So the vitreous was removed. Then tripod was injected and peripheral vitrectomy was done. So what we do is, because in a case of optic disc pit, the posterior vitreous plays a role in the optic disc pit maculopathy. So we had to remove the vitreous detachment. We had to do the vitreous detachment completely and thoroughly. Now this is a new modality, the intraoperative OCT. So here we can see the live retinal cross section that also depicts what we are doing right now on the surgery. So after a core vitrectomy, again peripheral vitrectomy, the whole of the vitreous has to be removed because in most retinal cases vitreous is the culprit. So proper vitrectomy has to be done. Now the dye is injected. This is a brilliant blue-green dye, blue dye, 0.25%. So this usually stains the inner limiting membrane. Then using the ILM forceps, we carefully peel the ILM. This is the inner limiting membrane that is being peeled. So we have to be very gentle because as we saw that if there is any de-roofing of the retina, that will lead to macular hole. So this has to be a very gentle process. Now 360-degree ILM peeling has been done and IOCT confirmed it. We can also see that the pit has, this is the pit and this is the ILM that has been removed. Then later it was fluid air exchange was done and 18% SF6 gas was injected and the ports were closed. Now coming on to the discussion. So what is optic disc pit? It is basically a cavitatory anomaly, mostly congenital, more associated with iridofundal coloboma. Sporadic cases have been seen with autosomal dominant pattern. Now systemic associations. So one of the most common systemic association with PIT is AICARDI syndrome. It's a rare genetic malformation syndrome, which is a neurodevelopmental disorder, mostly affecting female. So there's a triad, which includes absence of the corpus callosum, central chorioretinal lacunae, as you can see in the photo, and the infantile spasm. Other features that are associated, other ocular features that are associated with AICARDI syndrome are optic nerve abnormalities, and intellectual disability and scoliosis are also common, but no such association was present in our patient. Coming on to basal encephalocele, it's a rare encephalocele associated with other midline anomalies such as hypertelorism, broad nasal root, cleft lip and cleft palate. Optic disc anomalies such as pallor, dysplasia, optic pit, coloboma, and megalopapular have been reported. So we did the FARCAS of the Cantor index of our patient to find out if she had any hypertelorism. The value came out to be 40. If it's more than 42, we consider it as hypertelorism, and our patient had a value of 40, suggestive of no hypertelorism. The third syndrome that is associated with optic disc pit is ALAGILLE syndrome. It's an autosomal dominant inherited disorder with mutations of the JAG1 and NOTCH1 gene. Usually, patients presents to the physician with hyperbilirubinemia, pruritus, hepatomegaly due to underdevelopment of the hepatobiliary tree. Ocular associations seen in this syndrome are posterior embryotoxon, iris abnormalities, diffuse hyperpigmentation of the retina and choroid, and retinitis pigmentosa-like picture. Optic nerve drusen is very common in these patients, but optic disc hypoplasia, tilted disc, and optic disc pits are also associated. Now coming to the brief embryology of the eye, as we all know, the eye develops from the neuroectodermal part of the diencephalon. The optic stalk and the optic vesicle is formed at the day 27 and further. So the optic stalk later becomes the optic nerve. This is a cross section of the same, the optic stalk. So this is the inferior choroidal fissure through which the hyaloid artery enters and provides the blood supply in an embryonic eye. So at 7 weeks of age, this fissure closes and proceeds further for closing. But if there is any anomaly during this closure, it will lead to any optic disc anomalies. Now, embryology of the optic disc split is also said to occur at around 7 weeks. So, herniation of the dysplastic retina into a collagen-rich excavation that extends into the subarachnoid space through a laminar defect. It occurs early in development. The postulated hypothesis for optic disc split is abnormal defects in primitive neuroectodermal papillae folds or defective closure of the embryonic fissure due to poor migration of the mesodermal elements into the sclera. Now, optic disc maculopathy. So, maculopathy is said when there is subretinal fluid present. So, where does the subretinal fluid come from? It can either come from the vitreous, which has been evidenced by Indian ink in vitreous passing into the subretinal space, or gas or oil injected in the vitreous cavity passing into the subretinal space. But it has also been said that CSF can also leak into the subretinal space through the optic disc pit. Evidence again says that intracranial migration of oil in patients with ODP post-VR surgery has been seen, plus gas bubbles circulate out of the optic nerve sheath post-VR surgery. A point against the CSF fluid migrating in is that intrathecal fluorescein injection showed no connection. That is, the SRF did not show the fluorescein dye. Now, mechanism of fluid migration. There are two mechanisms. The first one is the vitreous traction theory. So, firm vitreous adhesion to the disc margin is frequently observed during surgery and is interpreted as evidence of vitreous traction. Hence, in our surgery, we did a proper vitrectomy with the posterior vitreous detachment. The second theory is the pressure gradient theory. The disruption of this normal anatomical feature by the congenital cavitatory defects allows vitreous or CSF fluid or both, again there is a controversy here, to travel down the pressure gradients, occasionally into the retinal stroma and the subretinal space. Now, the investigations when a patient comes to us with optic disc split is an OCT. So we can see this is the normal retina. Here there is Scheisses-like cavity. Scheisses meaning that there is intraretinal fluid, not just beneath the retina, but also inside the retinal layers itself. Plus, hyporeflective area is present. This is the edge of the pit. Coming to other imaging like infrared imaging and fundus autofluorescence, there is a circular hyporeflective area of serous macular detachment and hyporeflectivity at the fovea, and hyporeflectivity is seen at the disc and the disc pit. In fundus autofluorescence, there is usually granular hyperautofluorescence at the fovea with serous macular detachment. Now, fundus fluorescein angiography will show us an early hypo and late hyperfluorescence of the pit. You can see this is the hypo area. Later, it becomes an hyperfluorescence. So, this is the optic disc pit. Now, what is the treatment? So, this patient came to us with a vision of 3/60. We could have done a conservative management, but because the vision was so less and she was a 26-year-old female, we went ahead with the surgery. Conservative management is usually preferred in such patients where the vision is good. We can ignore an optic disc split without a maculopathy if the vision is good. So, natural, if left alone, it usually has a poor prognosis because chronicity decreases the prognosis of these patients. Now, the treatment that are associated with optic disc split maculopathy are laser, gas plus laser, macular buckling, vitrectomy with adjuncts, and pars plana vitrectomy with various adjuncts. Now, conservative treatment, 25% of the cases resolve spontaneously. Poor long treatment results in spontaneously resolved detachments. Aggressive treatment modalities can be used. Steroids in OTPM not effective as long-term basis because there are recurrences associated with steroids in ODPM. Now, laser and its modifications have been done. So, we can actually laser at the border of the optic disc pit. So, it provides a barrier to fluid migration into the defect. Argon laser photocoagulation has been used. Retina usually stays attached, but again, there has been occurrences of recurrence. There have been recurrences. Modification that can be used along with laser are, we can also inject an intravitreal gas, which will act as a tamponading agent. It compounds the effect of laser, and complete resolution improvement is seen in 75% patients by a study in Lee et al. Gas alone has evanescent responses. Now, these are few studies. These are again single center studies of only intravitreal gas injection. So, they say that there is initial improvement, but later recurrences do occur. Now, macular buckling. So, we can attach a sponge at the 6 o'clock or 12 o'clock position to support the macula. So it is like an external tamponade. We are pressing the macula from behind. Now coming on to vitrectomy. Vitrectomy along with traction release is the procedure that we have used. We have also done an ILM peeling, which usually shows a 10% failure rate with 40% redetachment and 50% attachment rates. So PPV with posterior vitreous detachment, air fluid exchange and laser versus PPV without laser have given us the same result. Hence, we did not laser the papillary pit. So these are a few studies that have shown ambiguous results. Some people do PPV with laser with gas. Some do a PPV with posterior vitreous detachment with laser with gas. Everyone has shown ambiguous result, and we have followed pars plana vitrectomy, a PVD, and ILM peeling. Another treatment that has been recently introduced is autologous plated plug. So we plug the optic disc pit with the autologous plated. So it creates a barrier for the fluid excursion. Newer modalities are inner retinal fenestration by Uta et al., which has not been tried in our center. Scleral flap seal and single temporal optic neurotomy, again to create a barrier between for the fluid excursion, and inverted ILM flap technique into the pit. Thank you. I now invite Mr. Rajpal to share his experience.
Thank you, Dr. Nayak. Now, I have already told you, whenever a case present with a serious detachment at the posterior pole, I will go from the basic because everyone, from the serious detachment, the most important thing is you must see the age of the patient and what are the other symptoms. And in such cases, you fully dilate the pupils into the periphery. Are you missing the retinal detachment or not? That is another finding which is missed. If you can't, if you see the center, because these optic pit with macular cases are only at the posterior pole, rarely they extend to the periphery. So that is important. And so that is why if you detect these things and not going to periphery, then the diagnosis is sure that this is optic pit with maculopathy. Now, with the advancement, ophthalmology is the one thing where there is a lot of advancement in the imaging. Earlier, we used to do only 90D examination and there is nothing else. But for the last 20 years, we have a lot of imaging system which can define the layer by layer. The only thing in these cases is if you find only optic pit and vision is good. So you can't do anything, vision is good. But what happens natural course of time is that as the age increases at 30 to 40 years, third or fourth decade, there is a liquefaction and there is a development of PVD, or sometimes without PVD, there is a retinocysis fluid which Q theory I have already told you, either from the retinal space or the vitreous. They causes the separation of the inner layers of the retina. Okay, and till then I have seen patients where vision is 6/6 and there is a separation of the inner layer of the retina. And the vision falls when there is a NSD, sensory inner retinal detach. In this, like in this case, this is the neurosensory detachment, and there are CSs inside. And in these cases, even vision is good, we can't operate. In such cases, we should follow serially. And in spite of having a 612, 618, suppose a patient comes to 612, 618. Now, because of the advancement in technology of surgery, like microscope, 3D system, all these things, the inherent complication of vitrectomy remains the same. So, ideally, you should think that we should operate early, but early operation does not have a 100% cure. Many of the study why we are not operating early is because you should operate early, 612 vision, 618 vision. If patient is conceived, you should operate. But the thing is, we don't know the pathogenesis, like in retinal detachment. Here we don't know what is the cause. Even in majority of the surgery, we have done pars plana vitrectomy, ILMP, or like lately fenestration or stuffing of the ILMP. The results are 50%, 60%. And there also, it takes longer time, 1 to 2 years in the absorption of the fluid. And there is a recurrences. And there is no study more than 5 years. So that is why there is a controversy. But even we have seen patients who have been operated, it takes 1 to 2 years in absorption of fluid. The only point is, whoever patient has come to us, suppose patient comes 6-18 vision, we operate, vision remain the same 6-18 vision. Okay, if he comes like C has come with this 1/60, C has improved. There is a 1 or 2 line improvement in the vision. But these patients are young and there is the inherent risk of vitrectomy, which is a cataract and the retinal detachment and so many. But if you follow these patients so that there is a chronicity, if there is a degeneration in the retina and patient is convinced, it depends on the both way. The patient is convinced, he understands the complication, all these things, then there is no criteria when to operate, at what reason to operate. But like this patient was ignorant of the reason, we tried, she was agreed because reason is too less. And if the reason is, so in these cases, the take home message is the identification of the ocular disease, any disease, you know, this is the optic pit, and whenever you should follow up serially yearly to do the, because 50 to 70% there is definitely going to macular sepsis. And how they will progress, we don't have a data. The longer duration, 5 years. So they progresses. Ultimately, they progress. 70% they progress. So later on, once in lifetime, they have to be operated. But on the other hand, 25% has been found to have a spontaneous absorption. So because of the rarity of the disease and because of the rarity, we cannot have a randomized study in these cases. The basic pathology in case like if suppose there is a simple regmatis in a retinal detachment, the only thing is break. You close the break, fluid absorb. So here we don't know the pathology. This is the thing. Anybody would like to ask a question? This is sufficient. Lights. This patient is 1 year old, 1 year old, and fluid is still there. As I already told you, vision is improved little bit, 3/60, but the fluid is same. As I have told you, it takes 1 to 2 years, and there is no long-term study, only literature, only 2 years, and the recurrence is there. So they come late because of the degeneration of the retina, chronic changes. Yes, we have seen patients going into ELPR, they generally become worse. But which patient will become worse, which will not, it depends on how the fluid is increasing or how CS is happening. There are multifactorial factors. Actually, we don't, with the advancement technology, we will be able to do the pathogenesis. That is why I have presented this. Thank you, Dr.